Hi, so in this part we are going to discuss about bronchial asthma. This is the part 2. Okay, so we'll be continuing it. Previous we discussed about bronchodilators. Now we are starting from leukotriene antagonist. So as I said before, we have referred KT Tripathi 8th edition and Tara for the class. Okay, so leukotriene antagonist. So what are leukotriene antagonists? You see, as this once the antigen comes in, IgE antibodies are synthesized. These IgE antibodies, they go and bind to the mast cell. Once they bind to the mast cell, antigen binds to this antibody, which leads to the degranulation of the mast cell. This degranulation of the mast cell, it releases histamine, interleukins, etc. Okay. These histamines and interleukins, they causes an inflammation in the bronchial, and this leads to asthma. So what is happening here? What are leukotriene antagonists? Leukotriene antagonists means they prevent the action of these leukotrienes, that is the interleukins, which are released from the mast cells. So they include montelukast and zafirlukast. They go and bind to the cystenyl LT1 receptors, which leads to bronchodilation, suppression of inflammation, and decreased hyperactivity. It is absorbed orally and is given as a prophylactic in case of mild to moderate persistent asthma. Now, some patients may respond very much to this leukotriene antagonist. Some patients may not respond to it. This shows the involvement of the leukotrienes in the asthma. Okay, leukotriene as the asthmatic mediator. Its adverse effects include headache, skin rashes, and rarely eosinophilia. The next class of drug is mast cell stabilizers. This mast cell stabilizers, it prevents the degranulation of the mast cell, which includes sodium chromoglycate and ketotelefin, which prevents the degranulation of the mast cell. Sodium chromoglycate is not effective orally and it is given as inhalation. Its uses it is used in allergic asthma as a prophylactic. It is also used in allergic conjunctivitis, rhinitis, and dermatitis, etc. Its adverse effect is due to local irritability. It does not have any adverse effect due to systemic. Okay, it does not have any systemic adverse effect. Due to local irritability, it causes cough, bronchospasm, headache, etc. The next class of drug we are going to deal with is glucocorticoids. Glucocorticoids are divided into two categories mainly. First one is systemic corticosteroid, the other one is inhalational corticosteroids. Under systemic corticosteroids, you're having hydrocortisone, prednisolone, and methylprednisolone. Under inhalational glucocorticoid, you're having beclomethasone, budesonide, and fluticasone. So, what does glucocorticoids actually do? They prevent the formation of the mediators. I said mast cell degranulates and it results in the release of mediators. This mediators formation is prevented. How? Glucocorticoids, it induces the synthesis of lipocortin. Lipocortin, it inhibits phospholipase A2. Inhibition of phospholipase A2 prevent the formation of the mediators. Now we'll first see inhalational glucocorticoids. Now, glucocorticoids, so as a whole, what they do is they suppress the inflammatory response, they decreases the mucosal edema, they decreases the bronchial hyperactivity, and in addition to this, they potentiate the beta 2 agonist action and it prevents the development of tolerance to beta 2 agonist. Therefore, it is given in combination with beta 2 agonist. Glucocorticoids are given in combination with beta 2 agonist, and I repeat, long acting beta 2 agonist cannot be given as such. It should be given only in combination with glucocorticoids. Glucocorticoids are given as a prophylactic of asthma. That which one? Inhalational glucocorticoids are given such. That is beclomethasone, budesonide, and fluticasone. Now we are going to systemic glucocorticoids or corticosteroid. It is given only in two cases. First one is in case of severe chronic asthma, the other one is in case of acute asthma exacerbation. In severe chronic asthma, which is not controlled by giving bronchodilators or inflammatory glucocorticoid, we give this we give systemic glucocorticoid. We start with prednisolone 20 to 60 milligram, and we continue it for 1 to 2 weeks, after which we finally attempt to reduce the dose and finally shift to ICS, that is inflammatory glucocorticoids. Okay, next one is in case of asthma exacerbation, asthma attack which does not respond to an intensive bronchodilator therapy, we give this. So we start with a high dose of rapidly acting intravenous glucocorticoids. Okay, and then which after which we shift to oral therapy. And we discontinue it abruptly, or you just taper rapidly. Taper means you reduce little by little. Next one is in case of COPD. You give it as a short course, 1 to 3 weeks course of oral glucocorticoid is found to be beneficial for some patients, especially during exasperation. The next kind of drug we are going to drill is anti-IgE monoclonal antibody. What does it do? It prevents the binding of IgE antibody to the mast cell. Example is omalizumab. It does not have any effect on those IgE antibody which has already bound to the mast cell. It's just that it prevents IgE antibody from binding to the mast cell. So this diagram is good. First one, omalizumab, prevents its binding to mast cell. The next one is mast cell stabilizers, which prevents its degranulation. Next is leukotriene antagonists, which antagonizes the action of leukotriene. Okay, and one more thing that we learned is glucocorticoids, which prevents the synthesis of uh, mediators. That is, to be precise, one important thing is this one, that is IgE, anti-IgE monoclonal antibody should not be given to patients who are less than 12 years of age. It is given in case of moderate to severe asthma and also in case of allergic disorder. It is administered parenterally. Next, what we are going to see is the treatment of asthma. So there are different degrees of asthma. How do you treat them? So when a patient is having a mild episode of asthma, that is symptom is less than once daily. So what do you give? You are giving inhaling short acting beta 2 agonist. That is enough. Next one is seasonal asthma. So when it comes to seasonal asthma, you should start regular low dose of inflammatory corticosteroids 3 weeks before the seasonal attack and continue 3 to 4 weeks after the season is over. Sometimes you can even give montelukast and zafirlukast. Next is mild chronic persistent asthma with occasional exacerbation. So in that case you give low dose of ICS, inflammatory corticosteroid. Sometimes you give montelukast and zafirlukast. I'll tell you, montelukast and zafirlukast are um, interleukin antagonists, that is leukotriene inhibitors. Okay, they may not be effective in some patients, however. Which one? Montelukast and zafirlukast. Okay, now, oral theophylline is less satisfactory option. Okay, next one is moderate asthma with frequent exacerbation. So when it comes to moderate asthma with frequent exacerbation, you give low doses of ICS with inhaled long lasting beta 2 agonist or medium dose of ICS alone. Leukotriene antagonist may be tried in place of long acting beta 2 agonist, but you see it has addictive effect. Okay, next one is sustained release of theophylline. Sustained release theophylline may be used as an alternative. Next is severe asthma. In case of severe asthma, what you give, you give regular high dose of ICS through a large volume spacer device plus inhale long acting beta 2 agonist twice daily. Or you can give and you also give an additional treatment with any of the following, which is you can give it with leukotriene antagonist or sustained released oral theophylline or sustained released oral beta 2 agonist. Okay, so in patients who are not adequately controlled or those who are needing frequent emergency care, institute oral steroid therapy while continuing long acting beta 2 inhalers and ICS. You see, the efficacy of the oral steroids is proven, but it should be the last resort. Okay, attempt to withdraw it should be made periodically. That is, you see, when you the last option for its treatment is the oral steroids, and you cannot withdraw oral steroids suddenly. You have to withdraw it little by little. You have to taper it. It should be done periodically. Next one is, how do you treat acute severe asthma? See, acute severe asthma. So what do you do? First thing is you give humidified oxygen inhalation, nebulized beta 2 adrenergic agonist you give, that is you give salbutamol or terbutaline, salbutamol 5 mg, terbutaline 10 mg, plus you give anticholinergic agent, so both of which they do bronchodilation. Then you do give systemic glucocorticoid, that is you're giving intravenous hydrocortisone 200 mg IV stat, okay, which is followed by IV hydrocortisone 100 mg or oral prednisolone 30 to 60 mg per day depending on the patient's condition. Okay, then next you giving intravenous fluids to correct the dehydration. Next one, you're giving potassium supplements because hypokalemia may be produced due to salbutamol and terbutaline. Next is you're giving sodium bicarbonate, which is used to treat the acidosis. Next is you give antibiotic in case there is infection in order to treat that. So this is how you do. First you give oxygen, then you make sure there is bronchodilation, after which you give glucocorticoid. Depending on the patient's condition, you decide the dose. Next you give IV fluids in order to prevent dehydration. Hypokalemia may happen due to the administration of the salbutamol and terbutaline, so you give potassium supplements. Then in order to prevent acidity, you give bicarbonates. You give antibiotics in order to treat the infection. Now what you need to remember is that once you have a patient with bronchial asthma, you should not give, these are the drugs to be avoided in patients with bronchial asthma. They are NSAIDs like aspirin, etc. But paracetamol can be used. Beta adrenergic blockers and cholinergic agents, both of which can cause bronchoconstriction. So that is also not used. So that's it about bronchial asthma.